Great. Welcome, everyone. Thank you for joining. This is an event we're really quite excited to present today. Prevent the Event, Virtual Management of Atrial Fibrillation and VTE. So this discussion and presentation has been developed by our faculty. Myself, I'm Vinai Bhagirath. I'm a hematologist in McMaster and Hamilton, and our other faculty members, including Dr. Vivien Brown, who is joining us today. She's a family physician in Toronto, Ontario, who has a special interest in preventive care, and in 2012 was awarded by the CFPC the Physician of the Year for Toronto. Also on the committee were Timothy Chan, Salma Shivji, Jeff Habert, and David Kaysen, representing physicians from across the country. We can move on to the next slide, please. Just in terms of disclosures, I have an unrestricted educational grant from Pfizer. Have some honoraria from Bayer and Pfizer, and Dr. Brown has Speakers Bureau and/or honoraria from CCRN, Amgen, Allergan, Bioscient, ASI, GSK, Merck, Moderna, Pfizer, Searchlight, and Sunovion, and consulting fees from Merck, Moderna, and Pfizer. This program has received financial support from BMS Pfizer Alliance in the form of an unrestricted educational grant. In terms of potential conflicts of interest, myself and Dr. Brown were eligible for an honorarium from Thrombosis Canada, and the BMS Pfizer Alliance may benefit from the sale of a product that may be discussed in this program. Go ahead, next slide. To mitigate this potential bias, there was a planning committee, which I introduced earlier, and it was peer-reviewed by Thrombosis Canada. Recommendations involving clinical medicine that we present are based on evidence that is accepted within the profession, having thrombosis experts and family medicine experts being represented. All scientific research that we'll refer to in this program conforms to generally accepted standards. Go ahead. So in terms of accreditation, we're happy to report that it's accredited for up to 1.5 main pro credits for the CFPC, and for the Royal College, a maximum of 1.5 hours under Section 3. Now, in order to get those credits, there's 4 steps. So step 1 is a pre-assessment questionnaire that's completed at the time of registration. Hopefully you've all done that. The step 2 is this 60-minute webinar. And at the end of that, this webinar, the step 3, which is an evaluation and post-assessment questionnaire, which can be done immediately following the webinar, and I'll give you the link at the end. Step 4 will be a reflective exercise, which will be emailed to you at 8 weeks afterward from now, and then you'll be able to get your credits. So our objectives today, what we're hoping is that at the end of this program, that you'll be able to determine when live or in-person care is appropriate for patients with atrial fibrillation and VTE. I think not just with the pandemic, but going forward in the future, this is going to be an ongoing issue and question. We'll discuss about there's a lot of considerations to consider about virtual treatment of atrial fibrillation and VTE, and we'll discuss those. And then we'll talk about some communication and learning tools that might be helpful for you and patients, and that can be shared electronically with them. What I'd like to do now is to turn things over to Vivien to start with our first case, which is Mandy, a case of VTE.
Thank you so much, Vinai. And so just so that you know the outline of tonight, we're going to talk about Mandy for a little while, and then we're going to open it up for questions, so that if you do have questions around VTE, we're going to answer them and have that discussion. And then Vinai's going to go on and present the second case on atrial fibrillation. So here we go. And it was really interesting as we developed these cases. We didn't put any tricks in it. There's no hidden agenda. It's really the kinds of patients that we actually see. So Mandy is 40 years old. She's a teacher. She called up for a virtual appointment. She just went to Mexico. There was a 5-hour flight. And on the return home, her calf was very painful and swollen. She went to the emergency room. She was diagnosed with a proximal VTE, and she was started appropriately on a DOAC. She's not short of breath. She denies any chest discomfort, but she wanted to keep you informed, and she had a couple of questions. Her past medical history shows that she's got generalized anxiety disorder, quite unrelated. She is overweight. She's got a BMI of 27. And the medications she's on are escitalopram, so she's on an SSRI, and she's on ethinyl estradiol 20 micrograms with levonorgestrel 100 micrograms, which really means she's on a birth control pill. So she's 40, she's overweight, she's on a birth control pill and an SSRI. Next slide. So she's got some good questions. She's a teacher and she wants the answers. How long do I need to be on this blood thinner? Was this caused by my birth control pill, and should I stop taking it? Can I use alcohol while on a DOAC? Can I still take painkillers for headaches and backache? And do I need other tests? Is this a warning of something else? What more do I need to do? Next slide. So from the get-go, Thrombosis Canada has some really excellent patient education information sheets. And I think our population today is quite savvy and quite IT educated. And one of the things that we can do is we can send them information so that they understand what their diagnosis is, they understand what the medication is, and it answers a lot of questions for them. You know, when people come to the doctor, either in person or virtually, they miss about half of what we say. They're anxious, they're thinking about their next question, and they may have a lot of confusion. So when we give them an information sheet, I think it's often very helpful. And it just so happens that Thrombosis Canada has put a lot of effort into these patient information sheets so that patients have a chance to read it over, understand what's going on, understand the treatment, and understand some of the issues around treatment. Next slide, please. We also have a video. And some people are visual learners, and we know that people are on their computer all the time. And so we can send people to an archived video on thrombosis for patients and their families. That way they get an idea of what's happened to them, and they have a better conception or perception of what's going on. Next slide. So let's talk about birth control pills, because this is a big one. And I think it's important that we understand that combined oral contraceptives are a risk factor for VTE. The magnitude of that risk depends on the progestogen type and the estrogen dose. And in women using therapeutic anticoagulation, use of hormonal therapy does not increase their risk of recurrent VTE. So right now, because she's on an anticoagulant, she can continue on the birth control pill because we know that the combination does not increase her risk. DOACs are the preferred treatment for VTE because of a lower incidence of major and fatal bleeding as compared to a drug like Coumadin and non-inferior efficacy. So we need to tell Mandy right from the get-go, no, you don't have to stop your birth control pill right now. We do have to talk about it for some future point, and we'll discuss what that point is when you stop the DOAC. We could consider discussing an IUD with Mandy to reduce the risk of bleeding and clots. And I think that's a good idea, but she may be overwhelmed right now. She started a new drug. She's got lots of questions. She may just want to say, you know, for the moment, leave me alone. Let me take my birth control pill and let's talk about this another time. Next slide. Well, she asked about testing. She asked, is there more that she needs to do? And so one of the questions is, do we need to look at her as being high risk for thromboembolic disease? And what we know is that thrombophilia testing is not required for most patients. We can consider it if it's going to make a difference in how we manage this patient, but basically right now she's on anticoagulants and it's not going to change what we're doing for the moment. We know that we may want to consult a specialist like Vinai if she's got concomitant arterial disease, an unusual family history, CBC abnormalities, an autoimmune disease. But the bottom line from what I've told you about Mandy is she does not need further testing at this time. Next slide. When we look at the question of testing, and again, this is an excellent patient information sheet that we really want to draw your attention to. What we know is that most people don't need testing. If you do test for whatever, life insurance may be more difficult if something is found. And sometimes testing is done at the wrong time and results can be confusing. It also uses up healthcare resources. And if it is an unusual situation like someone being pregnant or on estrogen, it really needs a personalized assessment as to whether you want to do further testing. So it's not an automatic. I saw a patient this morning with a DVT. It's not an automatic to do any kind of screening or family testing for the routine situation. Next slide. So what would you do now? Let's look at all the options. And if we were in a live event, we could ask people to put up their hands, but as we can't do that, just think about it for a minute. Would you review the risks and the symptoms of bleeding and recurrent thrombosis? Would you tell Mandy that therapy is for 3 months and then we stop? Would you tell Mandy that this is unprovoked and we should consider long-term therapy? What is an unprovoked DVT? Would we tell her that we're going to apply the HER2 screening at 6 months? And would we say, oh no, you're 40, you've just had a DVT, we should do a full cancer workup? So what do you think are the things that you would choose to do and how would you do them? Next slide. Well, she comes back to us 6 weeks later. This is a virtual visit. And what she says is that her periods have been really heavy, requiring multiple pads. And one of the questions is, how do you quantify heavy bleeding and what can we do for Mandy? Well, in terms of heavy bleeding, it really is different for different people. I think that when a patient tells me they're having heavy bleeding, one of the things I want to know is, are they using tampons and pads? And are they getting up at night to change? Are they not lasting 6 to 8 hours at night with whatever they've used? The other issue is that what one woman calls heavy bleeding is not what another woman calls heavy bleeding. There's a real variation in this. And so what I want to understand is how she interprets heavy bleeding, because what she's really interpreting is it's a big change for her. So whether or not the actual quantity is heavy, and there's all kinds of studies that have measured, you know, the amount of blood in pads and how often women change. The bottom line is she feels this is a big change. It's a change enough that she's come back to us. And so what can we do for her? Well, one of the things we may want to do is we may want to look at what medication she's on and whether or not we can make a change in terms of that birth control pill and the IUD. Next slide. Are we going to do things virtually or are we going to do things in person? Well, I think with Mandy, number one, I told you she's a teacher, and number two, I told you she's only 40 years old. So in general, I would think that she's a good candidate for virtual care. It's a relatively low complexity case. She's got high health literacy. She understands. I can email her those those patient information sheets. She's able to monitor her symptoms and access virtual care if needed. We can break up her multiple questions into chunk-sized visits or even an email. And generally, after teachers have had to teach online for 3 years, she's pretty comfortable with technology, whether video, phone, or email. I think we need to be careful in terms of setting up a workflow organization in order to arrange prescriptions and any investigations. So we need to be adept at our end in terms of virtual care, but I think a patient like this is a good candidate for virtual care. Next slide. When would you see her in person? Well, I would see her in person if something is more unusual. If she's developed some kind of post-thrombotic syndrome, if I'm worried that there's some kind of cellulitis or something unusual, if there continues to be this bleeding or an atypical symptom that has a high degree of uncertainty, if the technology and logistical difficulties arranging tests have impacted our visit, and if the patient feels more comfortable with an in-person visit. You know, I think this is really important. Whatever judgment we may make that she's good for this, she knows how to do it, she's young, she's IT savvy, for some people, they're much more comfortable with an in-person visit, whereas others are not or don't feel the need for that. I have a number of patients that are hard of hearing, and they find virtual visits almost impossible. Even though they can read lips, and even though you can speak loudly, they find it a much more difficult scenario than to be in the office in person. And so I think we have to offer our patients the option. And, you know, it may be that in a virtual visit is great. She doesn't have to waste travel time and park, and she knows where she's going, and the whole thing happens very quickly. But we can't presume that. And I find it, and I'm a family doctor, Central Toronto, I find it very difficult when sometimes patients tell me that a friend of theirs or their partner is seeing a doctor that will only see them virtually. I don't think that's fair to patients, and I don't think that that's what the college has told us to do. Initially, there was the preference for virtual care if possible, but not any longer. I think we need to be sure that we're doing what the patient is most comfortable doing. Next slide, please. So when would we escalate care? When would we be worried that something's changing and we need to do something more? Well, the biggest risk of a DVT is a pulmonary embolus. That's what we're afraid of. And so if the patient is having chest pain, if they're lightheaded, if they're out of breath, if they've got increasing leg tenderness or increasing leg swelling, the answer is to go to the emergency room. It's not to book an appointment to be seen in 3 to 5 days. You know, if we're really worried that maybe they've got something that has gone systemically, then we need to be very clear that they need immediate attention. Next slide. So Mandy comes back to us at 6 months. This is her virtual follow-up. And she's saying, can I stop this stuff now? I feel fine, everything's going pretty well. What do you think, doc? And we need to be able to answer this. And one of the ways we can answer this for women is we can do that HER2 screening. Next slide. Basically, what we can do, and this only applies to female patients, but from the reverse study, which was recurrent venous thromboembolism risk stratification evaluation, basically, we have a guideline that's going to help us decide what we do with ongoing coagulation, anticoagulation. So if we look at the various predictors, then we give them points. So the first predictor is signs of post-thrombotic syndrome, hyperpigmentation, edema, or redness in either leg. If she has that, she gets a point. We can do a D-dimer, and if it's greater than or equal to 250 micrograms per liter, she gets a point. If she's obese and her BMI is greater than 30, and if you recall in this patient, she was overweight, her BMI was 27, but she wasn't obese. And if her age is older, which is older than 65, if you recall, she's only 40 years old. If she's under 1 for her scoring, we can consider discontinuation. And if she's over 2, we're going to continue anticoagulation. So how does Mandy add up here? If you can click on the next slide. Yeah, Mandy is 0 all the way along. She doesn't have signs of post-thrombotic syndrome. D-dimer was okay. She's overweight but not obese, and she's not over the age of 65. So she is absolutely low risk, and we can consider discontinuation. Now, notice the word consider. There may be reasons why we don't want to consider discontinuation, and we can talk about those, and we can ask Vinny what some of the higher risk activities are that may make us want to continue. If she's high risk, greater than 2 points, we're going to continue the anticoagulants. Next question. Sorry, next slide. So what if she was 58, and what if she was on menopausal hormone therapy? And I want to make the distinction here. Menopausal hormone therapy, or what we used to call HRT, hormone replacement therapy, is actually about 1/4 the dose of oral contraceptives. It's much lower dose because you no longer are preventing ovulation because the woman is no longer ovulating. So I think this warrants an in-person discussion because the clinician's relationship with the patient and the patient's understanding of what benefit she's getting from MHT and what risk she's taking. And so one of the considerations is to review whether or not to stop MHT or to continue with anticoagulation. And we know that there's a diminishing risk benefit of MHT with the length of use, in that we know cardiac risk and breast cancer risk goes up minutely, but goes up with age. So if she's 58, do we want to continue this medication? Why is she on it in the first place? Is there still a significant benefit to her where she may want to continue hormone treatment as well as anticoagulation? Or given that she does have now a history of DVT, are we going to stop the hormone therapy? I think it's a really good question, and I have had this conversation in my practice a number of times, and I have a couple of people that have chosen to continue anticoagulation therapy long-term in order to stay on menopausal hormone therapy. A patient in particular has noticed significant cognitive issues, and on the hormone, she feels that those cognitive issues, specifically word finding, were not an issue, and she's tried stopping a number of times. So with the hematologist involved, because I was going out on a limb here, I felt, she has continued both on MHT and anticoagulation. Next slide. But what if she's got a BMI of 31? What if she's 66 and has a BMI of 31? Now her scores are slightly different. She's obese, and so that gives her 1 point. She's older age, she's over the age of 65, so that gives her 1 point. So now she's in the high risk range, and she's over 2, and we're going to continue her anticoagulant. Next slide. Well, what if Mandy's doing mostly okay, but now she needs a cholecystectomy? What do we do with the medication if we got her on long-term anticoagulation? And Thrombosis Canada has given us these answers, and Thrombosis Canada says we're going to stop the DOAC 2 days before surgery, so basically 2 doses, and that's our preoperative recommendation. And our post-operative recommendation is to continue the use of the DOAC 1 day after surgery, 24 hours later. Now, remember, we're going to watch when Vinny presents his case. Are the recommendations different if you've got atrial fibrillation compared to a history of DVT? We're in the DVT world right now, so we're going to stop it 48 hours before and start it again 24 hours afterwards. Yes, next slide. What if Mandy had been taking Celecoxib, which is the trade name Celebrex, thank you, for a bad back? What if she had been taking this non-steroidal anti-inflammatory for back pain? Well, we know there's limited evidence on the use of non-steroidals with the DOACs. We would rather people take acetaminophen, even as much as 1 gram TID, and avoid aspirin, non-steroidal anti-inflammatories, and the COX-2 inhibitors. but often people have significant pain and they absolutely want to be on a COX-2 or an NSAID. And we need to be very clear on most of the DOACs, and you can look at this chart, there is an increased risk of bleeding. When you start adding an NSAID, and that NSAID could be naproxen, it could be aspirin, whatever, you do get an increased risk of bleeding. When you are on warfarin and you're using a selective COX-2 inhibitor, there was an increased risk of GI bleeding, but not an increased risk of major bleeding. As a family doctor, I'm not comfortable with this. I'm very wary of using any kind of a non-steroidal or COX-2 in patients that are on anticoagulation. I'm afraid of it, and we know that we can see dramatic bleeds unexpectedly, often with no warning signs. Next slide.
So Vivien, we're getting some great questions here in the chat. If it's okay,
Sure.
Can I just pause and we'll just share those?
Absolutely. Let's go back a slide, please.
So there are a couple of questions about the HER2 rule, and maybe we'll just take a second to clarify. And the questions are basically around can we apply the HER2 rule to people who have estrogen-associated thrombosis, or is it purely for people with no provoking factor or no transient provoking factor? And the answer there is that so people who have like a hospitalization, orthopedic surgery, fracture, these sorts of things, they were not included, and those people we would generally stop at the 3-month mark. But people with estrogen-associated VTE were included here. Various studies have shown that they have somewhat of an intermediate risk of recurrence, even when the estrogen is stopped. And it's reasonable to use a D-dimer-driven approach, such as the HER2 approach. So it is, here we're presenting the HER2 approach, and in this they evaluate at 6 months rather than 3 months. I think it's a very reasonable approach, although there have been other approaches studied. So just in summary there, the HER2 rule, it's studied, applied at 6 months, and it can be applied to people with estrogen-associated VTE.
Right. And just to further that, when we start women on birth control pills, or we're starting women on hormone therapy, one of the questions is, have you ever had a DVT? And if they had a DVT, as Vinai just said, like post-op, or they had a DVT with a fracture, that's different than if they had a spontaneous DVT. And so I think we have to know our patient and know the history. Was there any other question that you want to discuss before we go on to the last few slides on this case?
Well, let's go ahead, and then we'll address other questions at the end.
Okay, so what if Mandy has been found to have a pelvic mass which is obstructing her iliac vein? It's like, this is worrisome, okay, no question. This requires in-person counseling, further testing, specialist referral. Now we're not talking DVT, now we're talking a mass with a secondary DVT. So this is a really important issue. And unfortunately, we do see women with pelvic masses that's often, not often, but occasionally can be ovarian cancers, can be massive fibroids, can be uterine cancer, can be various different kinds of cancers. Next slide. So here's patient education about cancer-associated thrombosis. And, I think patients need to understand that the thrombosis didn't lead to the cancer. It's the cancer that's leading to the thrombosis. And they don't always understand that. So whether it's mechanical, like an iliac mass, or whether it's related just because of the hypercoagulability with certain kinds of cancers, we need to educate our patient. And this is obviously something that needs our attention as soon as possible. Next slide. Okay, so that was the last slide. Why don't we open it up for questions and see if there is anything in particular people wanted to discuss that maybe got missed or glossed over. I like the concept of the what if, because it covers a variety of patient situations and helps us understand some of the details of some of the guidelines that we're talking about.
There is one question, Vivien, about completing the evaluation with the Doppler ultrasound. That's from Alejandro. Hi there. Good to hear from you. I think the question is about repeat ultrasound for baseline after therapy is completed.
So as far as I know, that's not required. Once you finish therapy, you finish therapy, unless the patient is having other kinds of symptoms. So unless she's having a recurrent DVT, and that would be, to me, a red flag that is there something else going on? Because if she's just finished anticoagulation, or if she has a DVT on anticoagulation, something else is going on. This is not routine. So I don't think routinely you have to do a Doppler, but I would absolutely want to review the patient before she stops the medication.
Yeah, so I sometimes will get a repeat if they have, especially if they have some residual symptoms, just more for documentation purposes. But it depends a little bit on how eager the patient is to do this, and but it is sometimes nice to have. But I agree, it's not a mandatory thing. We have a couple other questions. Applying HER2 for large volume PE. I can just offer my thoughts on that. I think if we get to the 6-month mark and someone is then asymptomatic and not having any symptoms of chronic thromboembolic disease, residual dyspnea, I'm pretty comfortable doing that. I don't necessarily volume of or severity of the PE doesn't necessarily sway me in terms of duration of anticoagulation, as long as their symptoms have resolved. Another question, I'm not sure I understand this one. Did D-dimer 1 month after stopping? Or do you, I think it's about repeat D-dimer. After, like, when the timing of the D-dimer, when is it done? While on anticoagulation or after anticoagulation?
I'm not sure. What would you do, Vinny?
Yeah, so in HER2, they have this lower threshold of just 250, and so that helps you decide about stopping anticoagulation, because you can do it on anticoagulation. You don't necessarily have to repeat it after stopping. The Dodd study did that approach, but that wasn't used in HER2, so not necessary. But if you were going to use a Dodd study type approach, you could then you could do that. We have a fibrillation case that I'd like to review. This is patient Frank, and we'll move on to the next slide here. So this is a 69-year-old man. He has a virtual phone visit with you today. He hasn't seen you in the office for about 1.5 years, but he's complaining now that he's been having palpitation for the last couple of weeks, and he feels his heart beating fast. They can last for hours at a time. He does have some symptoms of lightheadedness and dyspnea with that, but no angina symptoms. His medical history: hypertension, COPD, and osteoarthritis. He's on some antihypertensives, statin, inhaler, and ibuprofen PRN for his knees. Next slide. So a question here: do you think Frank needs to come in to be assessed? And what are some of the factors specifically that might make you think that we should bring Frank in for a visit at this time? And on the other flip side of that, what are you able to address with Frank on the phone, and what might need to be done in person? So when I'm thinking about what would make me want to bring someone in, there's some factors here that make me a little bit worried and about continuing purely by virtual care. So one is that it's been a long time since he's been last seen, 18 months. And so there may be things that we're missing. Another is that he's having some dyspnea and lightheadedness. These are a bit concerning, that he's having some end organ manifestations with the palpitations, and maybe he should be checked in person. There's some complexity here because there's many different things that could be causing palpitations and may need to be assessed in person. And then there are also some other things, factors here, that he's on some NSAIDs, for example. If we're thinking about an anticoagulant, it adds a little bit of complexity, which may favor an in-person assessment. And then lastly, and very importantly, of course, is that we would need to do an examination likely for cardiovascular status, including signs of heart failure, and that really would have to be done in person. So all of these things are making me think we should bring Frank in. Things that we can cover on the phone, though, is just to get more information from him about his symptoms, talk about any other health issues that have arisen in the interim, ask about is he adherent to his medications, and we can start to get a jump on tests for him so that they're available when he comes to see us. Next slide. So, questions being, what would you do here in this case? Would you tell him to call if he's still having palpitations next month? Probably not. There's some tests that need to be done now, and we like to see him in person soon. Another question is order an ECG and reassure it if normal. Although maybe that wouldn't be the only thing we do, it is reasonable to get one ordered to get things started. And similarly for a 48-hour Holter. Questions you might get about an Apple Watch. Maybe ask if someone in the family or he has an Apple Watch that he could use for a few days that might be able to assess for atrial fibrillation. Again, if he has access to one, it's certainly not much in terms of downsides or risks of using something like that while we're waiting to see him in person. Similarly, another device like a KardiaMobile online device that might similarly help get a jump on diagnosis. Echo can be ordered now, I think would be very reasonable, and some routine labs that could be booked at a local lab, so they could be available when you talk with him. And lastly, we would arrange to see him in office. Next slide. So let's say here that he purchased a KardiaMobile device online, and it's actually shown that he does have atrial fibrillation. So this would be similar to having a diagnostic test done otherwise. So we bring him in 3 days later. We see that the ECG is normal at the time of the visit. Labs show that his eGFR is 55. TSH is normal, electrolytes are normal, blood pressure is good, pulse is regular and normal at the time you see him. But we have a 48-hour Holter that's booked for 10 days from today. So a question would be, he's got this online diagnosis from the KardiaMobile device. Is that something that we would say is that's good enough, let's start some treatment based on that, or we're going to wait for a formal Holter monitor? So just to think about that, I think Holters are usually pretty much available, but some of the other tests can take some time to organize. And while we're waiting for these tests, it might be very reasonable to actually get started with some therapy for him, which could also always be scaled back. Next slide. So I think it would be reasonable to start some treatment now, even if all the diagnostics are not complete, especially if we think it's going to take some time to get the Holter monitor done and reported, or the echo is going to take some time. In the interim, we can treat with DOAC, for example, that has relatively low risks of bleeding, as long as we're explaining them clearly to him and he knows what to do, what would be a reasonable option to take. The last thing is not to forget that, Frank is taking some ibuprofen, and we want to counsel him about that. Probably a good idea to stop that, at least initially, until we sort of see how things are going with the DOAC. Next slide. Okay, so let's say now he's had his Holter monitor, and we don't, at this point, we've assessed him in clinic, we know that things are stable, and maybe we can just have a virtual visit for him after the Holter to discuss the results. And it does show here that he had atrial fibrillation for 12 hours with rate up to 135. The echo was normal. So the question is, what do we do now? What kind of therapy are we going to start initiating for him? Go ahead to the next slide. So there are some nice atrial fibrillation management guides and algorithms from the Canadian Journal, from the Canadian Cardiology Society. And here's one. It shows when you have a diagnosis of atrial fibrillation, as Frank does, first we want to look for reversible precipitants, and we checked, for example, his electrolytes and TSH in this case. Assuming that there's nothing really there to change, and really regardless, we're going to look at his thromboembolic risk, which we'll talk about in a minute. Think about oral anticoagulation to reduce the risk of stroke. We're also going to have to manage the arrhythmia component and have to consider whether to use a rate control or rhythm control strategy. But if he's feeling okay, we might want to go for a rate control strategy initially. And we also want to look at his other risk factors, cardiovascular risk factors in general, and make sure that those are optimized. Really to remember that the cardiovascular risk reduction and the anticoagulant, if indicated, are the things that are going to really help potentially improve survival for him. And then controlling the symptoms of the arrhythmia can help with reduction in healthcare utilization. Next slide. So going into some detail about the stroke prevention part of it, the CCS algorithm here makes it relatively simple, and I would encourage you to use this. So first thing is that you would see, does the patient have valvular atrial fibrillation? Meaning, if they have a mechanical heart valve, obviously they should be on anticoagulation with a vitamin K antagonist. But if they have moderate to severe mitral stenosis, regardless of the cause of that, that would be considered valvular atrial fibrillation. That patient should be anticoagulated because they have a higher risk of stroke. If they have hypertrophic cardiomyopathy, amyloid, acute hyperthyroidism, these things would be indications for anticoagulation. Otherwise, we go down this algorithm here. If their age is over 65, as in the case of Frank, we'd be thinking about anticoagulation as long as there's no contraindications. If they have these other CHADS risk factors, they would go for anticoagulation. If all of those are negative and the person has coronary or peripheral artery disease, then we'd be looking at antiplatelet therapy. And if they don't have coronary or peripheral arterial disease, we'd be looking at no antithrombotic therapy. So if they're true lone AF, as sometimes we hear that term, then they don't need any anticoagulation. So Frank here clearly would be a candidate for anticoagulation. Next slide. What about rate control? Just as a reminder, here's another CCS algorithm that you can use. Again, we're looking at symptoms or heart rate, resting heart rate over 100 beats per minute. And then the rate control agent that you use is going to be dependent a little bit on their ventricular function, and if they have reduced LVEF, then you'd be looking at a beta blocker. Otherwise, you can consider either beta blocker or calcium channel blocker. And then the next step would be looking at adding digoxin or beta blocker if you went with a calcium channel blocker strategy. If you're still having issues with symptoms or heart rate control, then you'd be looking at maybe having a cardiologist involved, if they're not already, to consider a rhythm control or a pacemaker strategy. Go ahead, next slide. So what about this kind of third arm of this, which is the adjustable factors that may be contributing to atrial fibrillation? And let's all think a little bit about what are your own best practices when you're addressing these issues virtually, because they can be a bit complicated to address virtually sometimes. So one good example of that is obesity. And I would like you maybe think a little bit about how might you address obesity and weight in a virtual setting. We can talk about hyperthyroidism, alcohol use, again, potentially a complicated one to do virtually, and maybe something that would be more appropriate to do in person, depending on the patient. If they're having infectious issues, if his COPD is poorly controlled, sleep apnea was an issue, and another point that'd be interesting to think about, how do you address or screen for sleep apnea in a virtual setting, checking blood pressure and other factors. Go ahead with the next slide. So let's say Frank feels well. Labs are all okay. Creatinine is as before. He's now wondering, can he stop his medications? Do we want to see him in person at this time? Can he stop his medications, meaning his anticoagulants and rate control agents? Go ahead, next slide. One thing that helps is to think about his bleeding risk, and you can use a HAS-BLED risk score. There are some other bleeding risk scores as well, Garfield AF, for example, but HAS-BLED is pretty easy to do, just to think through in your mind. And in this case, I won't go through in detail, but his score is 2 or 3. 2, but it would be 3 if he continues to use ibuprofen for his osteoarthritis. And you can see with the increasing HAS-BLED score, we're going to have an increased risk of bleeding. One of the things that we can do to help reduce the bleeding risk is just to make sure we're using the correct dose of his DOAC. And if they're on a VKA, effective INR monitoring. Lastly, we could add a PPI for people who might be also on ASA in addition to anticoagulants, or if they have another indication for PPI, we should be careful to add that. Next slide. In this case, with someone asking, hey doc, I'm feeling better, can I just stop my medications? Maybe paired with the fact that he previously hadn't really come to the office in a long time, had been kind of struggling with symptoms for a few weeks before he contacted you. This might be someone you might want to bring in and actually talk in detail to make sure he understands and the communication is clear about the risks and the rationale for using these therapies. He does need clear direction that he should not stop his anticoagulant, and he really has to understand what the risks of stroke are in that case. And so far, he hasn't had any real bleeding risk factors. Next slide. Something that can help here, again, just as Vivien pointed out so well, is that people don't always capture everything in a virtual or office visit, is you can give them some reading material. You can ask Frank, is this something that I could just direct you to the Thrombosis Canada website? I can email it to you with the link, or we can even print it out and mail it to them. And again, each patient is going to have their own preferred method. Go ahead, next slide. Okay, well, what about some complicating factors kind of to round things out here? What if his eGFR was a bit lower, was down to 40 with a higher creatinine? That might impact our dosing of the DOAC. And so just to be aware that renal function is one of the critical factors that will help us decide about DOAC dosing. And you can use the Thrombosis Canada has a tool for it to help with anticoagulant dosing. In this case, since his GFR is less than 50, if he was on, say, rivaroxaban, we might reduce his dose down to 15. Next slide. So here's a little slide that just goes over how you might change your dosing of various DOACs depending on renal function. But you can see that it's dabigatran, edoxaban, and rivaroxaban are all dose adjusted for creatinine clearance less than 50. And these studies, they mainly used a Cockcroft-Gault, but for the most part, this Cockcroft-Gault formula and EGFR align pretty well. And just to note that, when people really get very low renal function, we don't have a lot of data to gather to guide us on what's the best thing to do with dosing. And in those sorts of situations, you might want some specialist involvement. Go ahead, next slide. Another question that comes up is, what about pain? We do really want to avoid NSAID use with any kind of anticoagulant. We know that it increases the risk of bleeding, mainly GI bleeding. So we would counsel them to avoid aspirin and NSAIDs and even COX-2 inhibitors. The place to go is Tylenol, and make sure that he's taking Tylenol regularly. And then the question about adding narcotics, PRN, if appropriate for that patient, in preference to using NSAIDs. Go ahead, next slide. Another question, what if he needs a procedure coming up? Let's say we put him on a DOAC, but he has a history of polyps and he needs a colonoscopy. Again, we have a tool on Thrombosis Canada that can help you with interruption of anticoagulation around the time of procedures. In this case, if he's having a colonoscopy, generally speaking, he could hold the DOAC on the day of the procedure as long as his renal function is as it presented in the case. And then we would resume afterward, depending on whether he had a polypectomy done or not.
Yeah.
Go ahead, next slide. Last couple of things here. So what if Frank ends up in the ER with bleeding? So let's say in this case, he has some abdominal pain and black stools. They saw him in the ER. Hemoglobin was a bit low and ended up with a gastroscopy that showed a duodenal ulcer. Started PPI and iron, and his DOAC was stopped. Now, a question that comes up often is, when should we restart his DOAC? Go ahead to the next slide. The key thing, of course, is that the bleeding has to have stopped. As long as we're sure about that, and he actually has an ongoing indication for oral anticoagulation, then we have to balance out the thrombotic and bleeding risk. And this is an active area of research, actually. There's not no cut and dried answer about what to do. But generally speaking, is that for most patients who have a treatable bleeding event and risk, we would want to resume oral anticoagulation. For those who have an ongoing bleeding risk, we may need to discontinue. But the key thing is really talking to your patient and making sure they understand the risks of stroke as well as bleeding. And it has to be a shared decision between the patient and yourself. So we only have a few minutes left, but if we want to go to the take final questions maybe before the last slide.
Yeah, there's been a couple of questions, and I think one of them is particularly important, and that is, their question is that there's been some discussion about cardioverting people under the age of 65 who don't have ongoing risks. And is that what you would do first with AFib rather than putting them on an anticoagulant long-term?
So discussion about anticoagulant for cardioverted patients. So the first thing is that if you're going to be cardioverting, the patient does have to be on an anticoagulant and for some time afterward. And then the arrhythmia specialist can help guide. I know I've heard different things from different arrhythmia specialists. Some would say, we should continue long term because we don't have good data on stopping afterward. But the important thing to know is that they're going to want this patient on an anticoagulant before they cardiovert, so we might as well start it.
Okay. The other question that came up is, and I think this must be from a family doctor, that specialists always ask us to manage the anticoagulation when they want to do any surgery or colonoscopy. Shouldn't they be managing it? Because they're going to be deciding, are they doing the polypectomy or not? And, you know, we talk about shared decision-making, but how does this actually work in practice?
Yeah. So I will just say that this is an area that I'm actually particularly interested in. I think that we have a lot that we could do better in the area of periprocedural management of anticoagulation. I just will say that this is not something that we're going to be able to solve today. It is a major issue where no one really often takes ownership of this. In Hamilton, we have a bridging clinic. Thrombosis service is happy to help with these cases, but that's not always available elsewhere. So something that, as I said, I'm interested in. It's a worldwide, North America-wide problem, but we would encourage you to use the Thrombosis Canada website for that.
Yeah, and I would just echo that. I think as a family doctor, you want to know who's backing you up with what you're saying. And so if you're going back to Thrombosis Canada, going back to some of the guides, it's often very helpful when you've got a clear answer as to when to stop something and when to restart something, as we did with the DVT case. Another question, is it safe to put the patient on prophylaxis Tinsa while having a GI bleed?
Yeah, so my rule is if the patient is bleeding, then we do not anticoagulate. And there are very few exceptions to that. An example might be someone has a left ventricular assist device, like very specialized exceptions to that. Maybe if they have also having a very large burden of thrombosis, but in that situation, you know, they would be in hospital and they would have specialists involved. Generally speaking, no anticoagulation until we're sure the bleeding is done.
Right. In your clinical practice, if the patient goes on dialysis, would you treat at that point? What do you do then?
Like, so do we anticoagulate atrial fibrillation on dialysis? So I generally do, as long as there are no additional bleeding risk factors and if the CHAD score is higher. If they have a low moderate CHAD score, often will not. But if the CHAD score is 5 or 6, which often happens with comorbidities, and there's no additional bleeding risk factors, I generally will. But it's highly variable. Many nephrologists do not like to have their patients anticoagulated if on dialysis with atrial fibrillation.
Yeah. Vinny, believe it or not, we've already spent an hour and it has just flown by. I think that we want to thank everybody for their participation. We want to thank Thrombosis Canada for sponsoring the creation of this program as well as the presentation. And just by the numbers of questions and by the number of people that have been on, I know there's a lot of interest because this is very practical information that we deal with patients like this every day. I think it is important to think through some of the things we've discussed, hopefully make some changes in your practice, and really go back to Thrombosis Canada for the guidelines that are both practical, but also give you the authority to be able to say, yes, we're going to stop it at this point, or no, we're not. It helps you make that decision. And I think as a family doctor, that's really very valuable. Mm-hmm. Finally, Thrombosis Canada would love you to consider donating. It's an organization that supports the delivery of programs like this, creating the guides, working really hard to fill a gap in medicine across the country. And so if you would like more information, more resources, if you want to donate, go to thrombosiscanada.ca and see where you would like to participate.